Okay, good morning everyone. First, allow me to congratulate all of you on this International Day of Radiology, this great day in the history of modern science. And allow me to say that we are the eyes of medicine, and without us, medicine is blind. So, radiology rocks. And today I have chosen to present a talk about the MRI interpretation of sport related injuries of the knee. I'm Dr. Ahmed D. Abdulwahab. I'm a radiologist working in the Department of Radiology at Rizgary Teaching Hospital in Erbil, and I hope we will have a good time together. First of all, rapid introduction. The ligamentous knee injuries have been estimated to be approximately 98 per 100,000 per year. So it's a very common kind of injury, and we have to be well oriented about what can we see in it. The knee injuries are especially common in female athletes, and it may be a career-ending injury, especially for professional elite athletes. Today we will focus on the systematic approach to MR evaluation of the acute knee injuries, and we should keep in mind that in the setting of an acute knee injury, the physical examination will be limited due to the pain, swelling, guarding, effusion. So MRI will be of a very important test or exam for the immediate evaluation of the acute knee injuries. First of all, we will provide a rapid, thorough assessment of the individual structures of the knee, starting with the menisci. Menisci are usually torn due to rotational injuries that are most likely to produce meniscal tears. The tears of the menisci are classified into three grades: grade 1, 2, and 3. The grade 1 is a globular increase in the signal, which is not extending to any meniscal surface. Grade 2 is a linear increase in the signal, also not extending to a meniscal surface. Grade 3 is the important one, that is a tear extending to an articular surface. Please be sure to understand that it should be extending to an articular surface. It's either linear, which is called 3A, or globular, 3B. Only in this grade, arthroscopy is indicated and can be useful, because if the tear is not extending to an articular surface, arthroscopy will be negative, so it will be completely useless and of no therapeutic benefit to the patient. I think we are all familiar with this diagram of the meniscal injury. On the left side, we can see the grading of the meniscal signal abnormalities, grade 1, 2, 3A, and 3B. And on the right side, we can see the types of the meniscal injury. Here it's the radial tear, and here is a vertical longitudinal tear, vertical oblique tear, and D is the horizontal oblique tear. And you can see here a typical example of a grade 3A signal abnormality, which is an oblique tear extending to an articular surface. For me, personally, I don't like to mention like a grade 1 tear or grade 2 tear, because you never know what the person who will read the report, if he is oriented with this classification or not. I prefer to describe the tear and mention that there is an oblique tear involving the posterior horn of the medial meniscus, for example, extending to the inferior or superior articular surfaces of the meniscus, or even might be complex tear extending to both articular surfaces of the meniscus. And then I might add grade 1, 2, or 3, whatever, because this way I'm sure that anyone who reads the report will understand what I'm talking about. And I'm sure that if the patient underwent arthroscopy, it will be absolutely indicated according to my report. There is something called SQUINT sign. It is an informal sign. Simply, it means that if you have to squint your eyes in order to detect whether the tear is extending to the meniscal surface or not, it is likely not a true tear. It is not extending. If it is extending to an articular surface, it will be obvious. No need to squint your eye. If you have to squint your eye, it is not grade 3. It is either 1 or 2. Okay? Also, tears, as we said, are further classified by their shape as horizontal, longitudinal, oblique, what's called parrot beak, and radial tears. Most acute traumatic tears are oriented vertically. can be longitudinal, oblique, or radial, although in many cases complex configuration is present. Regarding what's called bucket handle tear, this kind of tear occurs when a longitudinal tear propagates both anteriorly and posteriorly, resulting in a fragment of the disc that is separated from the parent disc, and it usually displaced centrally into the intercondylar notch region of the joint, resulting in what's called the double PCL sign. However, sometimes the flap of the tear may fold back on itself in what's called a flipped meniscus appearance, with two triangular fragments pressed against one another. You have to understand that. Smaller meniscal fragments can be displaced in a variant compartment of the knee joint, including medial or lateral recesses, posterior recess, and into the popliteal recess. So you might have a bucket handle tear that is not presented with double PCL sign. Just keep in mind that the body of the meniscus should be seen on two consecutive cuts in a standard MRI examination of the knee. Two subsequent sagittal cuts of the MRI. If it is less than two, like one or no cuts, you can see the body of the meniscus, then this indicates a bucket handle tear, even if you don't see a double PCL sign. If it is more than two cuts, this indicates the possibility of discoid meniscus. Discoid meniscus is a normal variant in which the meniscus is bulky in size. So you can imagine it is larger than normal. When there is a tear, a bucket handle tear, and you chip away part of that disc, it will appear as a normal size. So it can be deceptive, and you should be careful from this discoid shaped meniscus. Regarding the ligaments of the knee, they include the ACL first, which is the most common ligament to be injured in the knee joint. We have primary signs which are sensitive and specific, including discontinuity, abnormal morphology, and abnormal increased signal intensity. Also, we have secondary signs, including they are less sensitive and less specific, including bone contusions of the lateral femoral condyle and posterior lateral tibia, also anterior tibial translation, uncovering of the posterior horn of the lateral meniscus, and buckling of the PCL, or the posterior cruciate ligament. This is the anterior cruciate ligament, the normal one, and you can obviously see the difference from the torn anterior cruciate ligament. Regarding the posterior cruciate ligament, usually it occurs as a part of complex injuries. It needs a large trauma, large force to be ruptured. So it also can be presented with partial or complete discontinuity, can appear as amorphous signal, increased signal intensity in the ligament, with bone avulsion of the tibial attachment easily or readily seen. You can see here this is the normal posterior cruciate ligament, and here it is an abnormal irregular posterior cruciate ligament indicating a tear. Regarding the medial collateral ligament, the MCL, signs in detecting MCL injury are either focal disruption of the fibers, thickening, and abnormal increased signal within and surrounding the medial collateral ligament. This is the normal medial collateral ligament. You can see it very well identified as a hypointense structure along the medial aspect of the knee, and here it is an irregular torn medial collateral ligament with surrounding soft tissue edema. Regarding the in the posterolateral aspect of the knee joint, there is a combination of tendons and ligaments, all together referred to as the posterolateral structures, and they are the major components include fibular collateral ligament, arcuate ligament, popliteal tendon, popliteofibular ligament, and fibullofibular ligament, with contribution from the iliotibial band, biceps femoris tendon, lateral gastrocnemius tendon, and joint capsule. So they collectively they are referred to as the posterolateral corner structures or posterolateral corner injuries. They will involve multiple of these structures. However, I want to just focus on one of them, which is the popliteus muscle. We have both muscle rupture or injury and popliteal tendon rupture or injury. The muscle injury is more common, will be presented by edema and swelling and discontinuity, but it is less specific, while the tendon rupture, which is usually shown as discontinuity with a wavy appearance of a partly retracted tendon. So the muscle is more likely to rupture than the tendon. Regarding the articular cartilage of the knee joint, the injury mechanisms include transient patellar dislocation, and anterior cruciate ligament injury. When the with ACL injuries, the osteochondral injury occur at the site of impaction of the anterior lateral femoral condyle and the posterior lateral condyle, resulting from anterior translation of the tibia at the time of the ACL rupture, resulting in cartilaginous injury termed osteochondral fracture. There is what's called delaminating cartilage injury. They may be subtle, with linear fluid seen between the cartilage and the subchondral bone. With the displaced cartilage fragment can be removed from the donor side, and these fragments can be difficult to identify if the joint effusion is not present, because we are primarily looking for the fluid of the joint effusion that is tracking deep to the articular surface, articular cartilage, between the articular cartilage and the underlying bone. So this is a delaminating injury. Regarding the bones of the knee joint, impaction injuries will produce areas of edema. While avulsion injuries produce smaller abnormalities, localized smaller areas of edema localized beneath the avulsed structure. We should keep in mind that the bone contusions can be either contiguous or non-contiguous. Contiguous bone contusions denote an injury occurring in extension, while non-contiguous contusions usually occur during abnormal translation of one bone over another, usually in flexion. As in this diagram, you can obviously see the different types of bone contusions. Here, it's the type of bone edema, bone marrow edema that results from avulsion fracture. It's small and localized to the site of the avulsion. While here you can obviously see impaction fractures. The bones are or contiguous kissing contusions that happens usually during extension injuries. They are adjacent or opposite each other. While here there is the non-contiguous contusions which occur during translation during the acute injury. They are not opposed to each other. There are certain but important fracture that may be very subtle on MRI, including second fracture, reverse second fracture, and fibular tip avulsion. The last thing to be reviewed during examination of the knee MRI is the periarticular soft tissues, which are localized soft tissues, which usually presents by localized soft tissue swelling or hematoma, and usually denotes the site of the direct blow force. Can result also hemarthrosis and lipohemarthrosis can be seen within the knee joint capsule, which can as 2 or 3 distinct fluid layers. Localized deep soft tissue swelling is also a sign of likely adjacent ligamentous, capsular, or meniscal injury. Now I want to discuss a pattern of approach to the knee injuries that depends on the mechanism of the injury. The mechanism-based pattern approach to the knee injuries. When we know the mechanism that caused the knee injury, we can identify additional at-risk structures, which might be missed if we don't have the mechanism of the injury. Injuries that occur as a result of pure or single force are unusual. There are 10 distinct mechanisms in which the knee joint can be injured. Luckily for us, only one of them is common, and the rest, the other 9 mechanisms, are either uncommon or rare. First, we will start with the first mechanism, that is pure hyperextension. A pure hyperextension, it is a rare mechanism of injury which result in, you just need to imagine when the force occurs, when there is hyperextension, the injuries will occur at the tibial aspect, or the opposite side of the force, the exit side of the force, if you might say. So in a pure hyperextension, there is a broad impaction type bone contusion or fracture at the anterior central tibial plateau and anterior femoral condyle. That's the site of the impaction. However, the injuries will occur posteriorly. There is a posterior capsule rupture, and corner injuries may occur. ACL or PCL injuries may occur with sufficient force. There can be frank knee dislocation. For example, just imagine this knee joint being hyperextended. Okay, so you will have contusions anteriorly, like here, okay, and here also at the A, and you can see posterior edema at the soft tissues of the popliteal fossa due to the distraction injury. Also, you can see here a posterior capsule rupture and the PCL tear at the posterior aspect of the knee joint at the popliteal fossa, which is the force is hyperextension, so posteriorly the injuries will happen. The second mechanism is hyperextension with VARUS. So you can imagine if it is hyperextended and the leg is directed towards the midline, it's an uncommon form of injury or mechanism of injury, result in impaction bone marrow edema at the anterior medial tibia and anterior medial femoral condyle, because the leg will be directed towards the midline, so the site of impaction will occur at the anteromedial aspect of the bones, since the injury is the force is directed medially and anteriorly. The injuries will happen at the posterolateral aspect of the knee joint, so there will be additional ACL tear and possible avulsion of the proximal fibular tip. So when there is varus deformity, the lateral aspect will be more injured. Like in this example here, you can see evidence of anteromedial bone marrow edema at the femoral condyle, and you can see posterolateral injuries here at the posterolateral structures, and you can obviously see the ACL that is completely missing, and also you can see posterior capsular rupture as we saw in the pure extension injuries. The other mechanism is hyperextension with valgus. This will be the same idea with the varus deformity, but the abnormalities will occur in the posteromedial aspect. There will be bone marrow edema at the anterolateral proximal tibia and anterior lateral femoral condyle, and will result in posterior cruciate ligament tear, and posteromedial corner may be accompanied by small posterior medial tibial rim avulsion. With the varus deformity, there were fibular tip avulsion. Here we have tibial rim avulsion. As in this case, for example, you can see hyperextension with valgus injury resulting in anterolateral, tibial and femoral injuries, and you can see the PCL injury or tear. Also, posterior capsule is ruptured here because it's an extension injury, so always posterior capsule will be affected, and you can see here a tibial avulsion and MCL tear. This is the medial collateral ligament here torn, and you can appreciate the avulsion fracture due to the pull by the medial collateral ligament. Here is the tibial fracture, and here is the medial collateral ligament. Now we will get rid of the extension. We'll deal only with varus or valgus abnormality. Regarding the pure valgus abnormality, it's uncommon. You can imagine the leg is moving away from the midline. This is called clipping injury, resulting in contiguous impaction type bone marrow edema of the lateral tibia or lateral femoral condyle, and small avulsion bone marrow edema seen involving the medial condyle or medial tibia at the insertion of the deep medial collateral ligament. Can be partial or complete medial collateral ligament injury. Severe valgus will lead to additional ACL injury and medial meniscal tear, and these three injuries called the O'Donoghue triad. We can see here it's a pure valgus pattern in which we have bone marrow edema at the lateral femoral condyle, and we can see the MCL injury here and here, and obviously you can see the ACL tear. The opposite of that is the pure varus mechanism. It's also a rare mechanism. The leg is moving towards the midline without flexion or extension, so there will be impaction bone marrow edema at the medial tibial and femoral condyle, while in valgus it was the lateral tibial and femoral condyle. Here we have the medial tibial and femoral condyle with soft tissue injuries and the iliotibial band and fibular collateral ligament band injuries. As you can see here, there is bone marrow edema at the lateral aspect of the tibia and the at the medial aspect of the condyle, femoral condyle, and fibular collateral ligament injury. You can obviously see here, this is the fibular collateral. This is the site of impaction at the medial aspect, while at the lateral aspect is the site of rupture of the ligament, the fibular or lateral collateral ligament injury. In this case, the ACL was also torn, you can see here. Okay, so you have bone marrow edema at the medial aspect, and you have ligamentous rupture at the lateral aspect. Now, a little bit more complex mechanisms of injury. This is the most important mechanism because it is it accounts for like half of the all complex knee injuries. It is the only one that is common, which is flexion valgus with external rotation. Flexion valgus with internal rotation. So with external rotation. So you can expect to see non-contiguous impaction contusion of the mid-lateral femoral condyle or posterior lateral tibia. Bone marrow edema at the posterior medial tibia or medial femoral condyle is also present. The ACL is completely torn and there is variable injury to the medial collateral ligament, and the posterior lateral corner is occasionally injured. Both medial and lateral menisci are at risk of tear in this mechanism. So there will be non-contiguous impaction of the lateral femoral or tibial articular surfaces. Also, there will be bone marrow edema at the posterior medial tibial or medial femoral condyle, and the ACL is completely torn with risk of rupture to either menisci. You can see here, obviously, the meniscus is torn. The lateral meniscus is torn. You can see the ACL injury here, and you can see here the typical contusion pattern involving the anterior lateral femoral and posterior tibial. Here there is some mild bone marrow edema at the posterior tibial aspect and the articular surface of the lateral femoral condyle. Again, there is incomplete medial collateral ligament injury here. The next mechanism is a flexion varus with internal rotation. Flexion varus with internal rotation. So it's almost opposite of the previous one. It is a rare mechanism, usually resulting in what's called second fracture, which is an avulsion of the lateral capsule insertion of the tibia. There will be complete ACL tear, non-contiguous impaction contusions in the lateral condyle and posterior lateral tibia. The posterior lateral corner injury will be obvious, and both medial and lateral menisci also may occur. So in both these mechanisms, the menisci can be torn. You can see here in this image that there is a second fracture here. The second fracture here, and there is an ACL tear. So when you see second fracture due to the collateral ligament injury, it will be due to this mechanism, the flexion, varus, and internal rotation. The next mechanism is flexion with posterior tibial translation. You can imagine in flexion when there is a posterior tibial translation. It's an uncommon mechanism. As we said, when there is tibial translation, the bone marrow edema will be non-contiguous, and in fact there might be no contusions at all, or just bone marrow edema at the anterior tibial tubercle at the site of the blow. It resulted in an isolated PCL tear, which is a very uncommon or unlikely finding, the isolated PCL tear. You can see here there is an isolated PCL tear with a bone marrow edema here that is a result of the direct blow resulting in posterior tibial translation. Patellar dislocation is an uncommon injury with usually associated with femoral trochlear hypoplasia, non-contiguous impaction bone marrow edema at the anterolateral aspect of the lateral femoral condyle and the medial patella because they touch each other in the dislocated patellar position, associated with chondral or osteochondral injury to the patella, and the injury because the patella will be displaced laterally, so the medial retinaculum will be injured, the medial patellofemoral ligament, the medial patellotibial ligament also may be injured. You can see here, imagine if this patella was dislocated here laterally, this articular surface is impacted against this articular surface, resulting in bone marrow edema at the medial aspect and of the patella and the lateral femoral condyle, and the medial retinaculum and the medial ligaments will be torn or injured, associated with some joint effusion, of course. You can see here. You can see here also osteochondral fracture. There is some loss of the articular cartilage over this part. The last mechanism, it is a direct blow to the knee joint. It is an uncommon mechanism who result in impaction contusion with bone marrow edema at the site of the blow. The soft tissue might be edematous, or can be a hematoma can form there. No ligamentous injury is seen. With older injuries, the bone contusion may persist longer than the soft tissue abnormality. So if it is old, you can see bone marrow edema with normal soft tissues. This also is indicative of a relatively old trauma. And luckily, there will be no significant internal derangement. As you can see here, this is a T1 weighted image. You can see this bone marrow edema at the site of the direct blow, and there is no soft tissue abnormality, indicating relatively old fracture, and this causes no internal derangement. This is like the best kind of knee injury you can have. So in summary, first, we need to know that the MRI is a reliable and cost-effective diagnostic tool in evaluating the extent of the acute knee injury. A systematic approach to the assessment of the key structures of the knee, including bone, cartilage, menisci, and ligaments, requires detailed knowledge of the normal anatomy and anatomic variants, as well as the expected MRI appearance of the injury. Using mechanism-based injury pattern can help in recognizing the complete extent of complex knee injuries. This will be my presentation for this amazing International Day of Radiology, and I would like to thank you for listening to me and to thank the Kurdistan Association of Radiology for holding this great big event, and hope to see you next year with another presentation and this at another lovely gathering. Thank you very much.